Good afternoon, everyone. I want to welcome you to our webinar for the month of October. Today we're going to be doing cervicogenic headaches, layered approach. It's going to be presented by Dr. Phil Page, and it's going to be moderated by myself, Doug Johnson. I am the Senior Vice President of Clinical and Scientific Affairs for Multi-Radiance Medical. I attended Wayne State University and the University of Detroit Mercy. I have a Bachelor's of Science in Sports Medicine. I'm also the co-owner of Sports and Industrial Rehab here in Taylor, Michigan, and I am the, as I said, Senior Vice President of Clinical and Scientific Affairs. I do most of the protocol writing, research, and those things. Right now we're working on athletic performance. So I'd like to, we're going to do a little bit of housekeeping today with our presentation. One thing I want to just make sure, we're going to state our notice of copyright. The material information presented is copyright 2011 by Multi-Radiance Medical and Dr. Phil Page. I want to provide our disclaimer. Some of the information provided is a guide only. It may contain information that is considered off-label use. The publishers, authors, moderators, and presenters make no claim that phototherapy, laser light therapy, and/or multi-radiance therapy will be effective in treating any conditions listed in this presentation or publication. Individual practitioner discretion is essential in determining the appropriate course of treatment for your patients. With that out of the way, we're going to do a little bit more housekeeping for the webinar today. We're going to do a Q&A session during the last 15 minutes. We're going to have 3 interactive polling questions that we're going to ask you. Go ahead and answer those as quickly as you can so that we can get back to the content. You can send any questions that you have during the webinar at any point in time. And we recommend if you do have questions in particular to the topic at hand today, make sure you send those in early so that we can prioritize those for the Q&A session. If you do have any questions, you can email us at webinar@multiradiance.com for any additional questions or comments that you may have on our webinar today. And today's presenter is a good friend of mine, Dr. Phil Page. He's a DPT, PT, ATC, CSCS, great guy down here. He's going to be going over this layered approach for us for treating cervicogenic headaches. He's a graduate of Louisiana State University in physical therapy. He received his master's degree in exercise physiology and his doctorate in kinesiology from LSU. Dr. Page has been involved in rehabilitation and sports medicine for well over 20 years. Since 1998, he has been the Director of Clinical Education and Research for both thera-band and BioFreeze products. And you know we've mentioned those products several times as far as utilizing them with laser therapy. His clinical and research interests include the role of muscle imbalance and musculoskeletal pain and promoting physical activity for health-related physical fitness, particularly for chronic disease management. And with that, I'd like to welcome Dr. Phil Page to our webinar today.
Thanks, Doug. It's a pleasure to be here and have all of our listeners thank you for joining us today. I know cervicogenic headaches are an interesting topic to some people, and I wanted to take the time today to go over kind of the current concepts to create an evidence-led approach to how we can manage them clinically. So in order to do that, what I wanted to do today was show clinicians how we can recognize and differentiate cervicogenic headaches and provide some of the evidence behind the non-pharmacological treatments of those types of headaches, as well as how to integrate different interventions with joint mobilization, laser therapy, and therapeutic exercise. So we'll start off by describing headaches in general are classified by an international classification of headache disorders. There are primarily 2 types, the vascular or muscular type, and then there's a secondary type of headache, which is what we're going to be talking about today, that includes the cervicogenic variety. This is an important topic because half of the population has a headache at one time. In terms of the specific cervicogenic headache, we can define it literally as a headache of cervical origin. Dr. Shostad in 1983 actually coined that term, and they found that about 15 to 20% of all headaches are cervicogenic related. There tends to be more cervicogenic headaches in adults who have neck pain as well as females. Now, the actual pathogenesis, pathomechanics of a cervicogenic headache aren't necessarily well known. There are some good theories out there by Dr. Bogduk and Shostad, and what they talk about is how the proposed mechanism of these types of headaches is from the convergence of the first 3 cervical nerves into that trigeminal cervical nucleus, which has that direct feed to the trigeminal nerve, which they theorize causes that headache as it relates to some type of neck pain or pathology. So with that, we'll start our first poll question.
Excellent. Thank you, Dr. Page. One of the things we'd like to know during this first poll question is we want to know your understanding and your comfort level with low-level lasers and kind of what your current status is. Do you currently own a multi-radiance medical laser? Do you own another manufacturer and considering a second unit? Do you currently own another manufacturer not interested in another unit? Are you currently evaluating a laser therapy device at this time, or are you participating here for education purposes? I definitely know, Dr. Page, there's a lot of people on this webinar. We've gotten some great questions already, so the topic and interest is really high into this. I know that a lot of people have asked us to do this. So basically about 66% of everybody on our webinar currently own a multi-radiance medical laser. So this webinar will certainly be able to help you out in understanding kind of this approach that Dr. Page is going to be presenting today.
Thanks, Doug. Let's move on now to talking about how can we assess a cervicogenic headache and create that differential. As with all pathologies we see clinically, a good assessment will always begin with a good history. And this is very true for a cervicogenic headache. The hallmark are going to begin to show in the symptoms, especially when you have neck pain associated with headache pain. You also want to look at the occurrence of trauma versus no trauma. There tends to be some type of traumatic event. With anyone with a headache, particularly in a female, you have to rule out menstrual headaches. Those types of headaches tend to be undiagnosed, and you want to make sure that you rule those out as well. Responses to medication can always cause a headache, and always look at imaging results. And someone who has a chronic headache, they tend to be normal in these situations. As with any diagnosis in the clinic, we have to be aware and really concerned about our red flags. Those are the signs and symptoms that tell us that something more serious is going on and we need to take a better look at it. If your patient comes to you and they have headaches that are getting worse, if they have a sudden onset of a severe headache, or if that headache is associated with a high fever, stiff neck, or a rash, or if there's an onset after a recent head injury, then those things need to be evaluated further beyond just the normal headache or cervicogenic origin. Now, if we take a look at those signs and symptoms, these are, again, the hallmarks that Dr. Bogduk has provided clinically to note that a cervicogenic headache is unilateral. It begins from the posterior portion of the head and moves anteriorly. Generally, the neck pain precedes or coexists with the headache pain. We typically don't see a headache and then neck pain. Either the neck pain starts or they occur at the same time. The patient complains of a locked sensation of their upper neck. And another important thing is that the headache is aggravated by sustained neck posture or repetitive movements. With this type of musculoskeletal impairment, we always follow a standard assessment to help not only to find out what's going on, to help rule out other things, but to help get us an idea of how some of the impairments and limitations we need to address with our patients. So we'll go through these 6 steps of posture, range of motion, muscle length and strength, a manual assessment, and soft tissue assessment. And these 6 tests are basically what we do for any type of chronic musculoskeletal condition, whether it's a headache with neck pain or low back pain or anything like that. What I wanted to do was to kind of try to relate the literature to these steps in the evaluation. The first step we always do is look at posture. Posture within itself is not diagnostic, but it can start to give us some clues as to what's going on. There's some conflicting evidence in the literature. Some say cervicogenic headaches are associated with this forward head posture. Some say it's not. Generally, if you see someone who has the forward head, increased lordosis of the cervical spine, rounded shoulders, increased kyphosis, that's our first clue that something is going on with that upper quarter. The next thing we'll look at is their range of motion. We're going to have them just sit there and go through the cardinal planes of motion of the cervical spine. Again, the literature is a little bit conflicting to note that do patients with cervicogenic have decreased neck range of motion? Some say yes. As a matter of fact, most say yes. Some say no. What's interesting is that the intensity of the headache is generally inversely related to the amount of neck range of motion. So what we see is that the more intense the headache, the less the range of motion in the cervical spine will be. And that's another one of those diagnostic clues that we can use to start thinking cervicogenic headache. Next, we'll take them into our standard muscle length tests. You're going to use the standard tests for muscle length, particularly looking at these specific muscles. And you can see that from this chart there are actually higher incidences of specific muscle tightness in patients who have cervicogenic headaches compared to those who have migraine headaches and controls. These muscles that tend to be tight in the cervicogenic headache population are levator, upper trapezius, pectorals, and the sternocleidomastoid. Now you might start to see a little pattern come out of this and to say, those muscles sound familiar. Keep your eye on those muscles for a second. The next test is probably the most important clinical test that we see in the literature, and that's the craniocervical flexion test. This is not only used for cervicogenic headaches, but it was developed by the Australians who used the stabilizer inflatable cuff, if you will, or inflatable pressure biofeedback device in their work with transverse abdominis and the multifidus and chronic low back pain. What they did was just modify the procedure for the deep neck flexors, where what they do is they place the inflatable cuff underneath the cervical spine, as you can see in the picture, and then inflate it to 20 millimeters of mercury and have them do a chin retraction or craniocervical flexion. It's not actually lifting the head, it's actually pulling the chin back towards the cervical spine, holding those for 5 seconds and gradually increasing the millimeters of mercury until they get to 30. Those who have weak deep neck flexors have poor performance on this test and aren't able to go above 22 millimeters of mercury. Another test described in the literature for deep neck flexor endurance was noted by Harris, and what they do is have the patient lie supine, again perform the chin tuck maneuver and lift the head gently off of the table a few inches and see how long that they can hold it. And you can see from their study, patients who have neck pain aren't able to hold that as much as those who don't have neck pain. The next part of the assessment that we do is the manual assessment. This is an interesting and important point because what we see is that headache and neck pain, when in combination, can be signs of a vertebral basilar artery dissection. If this is the case, this is a possibility of someone eventually getting a stroke from a subsequent manipulation or something like that. What we see is that if you have a patient that has the two symptoms presenting at the same time, we always need to perform the VBA test in these patients to rule out some type of vascular problem at the base of the head where that vertebral basilar artery goes. Now, not all of these patients that have cervicogenic headaches are going to obviously be at risk for a stroke or something like that. We just need to make sure that we're ruling that out as one of those red flags before we go any further with our assessment. The best test that's out there that's very specific to cervicogenic headaches is the cervical flexion and rotation test. It has very high sensitivity and specificity. And what we do is we lie the patient supine, maximally flex the cervical spine passively, and then rotate either right or left or both, and look for decreases in range of motion, right or left. What this test does is it helps to isolate the upper cervical rotation so we can get a good idea of exactly how much upper cervical rotation we have or don't have. We obviously would follow that up with a general evaluation of all of the cervical joints in terms of their joint mobility. And finally, we look at the soft tissue. In patients who have these types of headaches, they generally have trigger points in the suboccipitals, sternocleidomastoid, scalenes, upper trap, levator, and temporalis. Again, these muscles seem to be similar to the ones that are shown to be tighter or more frequently tighter in patients who have cervicogenic headaches. The reason why we bring up those muscles is that starts to show us that cervicogenic headache patients have basically Yanda's upper cross syndrome. For those of you who are familiar with Yanda's work, he was a Czech neurologist who was a pioneer and researcher in muscle imbalance movement impairments. And he recognized his upper and lower cross syndromes and recognized that these types of syndromes were prevalent in patients with chronic musculoskeletal pain, whether they had a problem with their low back or their cervical spine. Even patients with shoulder pain or knee pain sometimes exhibit these cross syndromes. When I looked at the literature in terms of chronic neck pain, cervicogenic headaches, I was very interested to see that many studies basically agreed that these patients have the presence of the characteristic upper cross syndrome of muscle imbalance that Yanda described. The weak, deep neck flexors with weakness of the lower trap and rhomboids, which are countered with the tightness of the pectorals and the upper trap, levator, and suboccipital muscles. So in the literature, there's several studies that looked at, if you will, use the term epidemiology of this presence of imbalance. And there's also several case studies that describe how the presence of Yanda's upper cross syndrome is present in cervicogenic headaches. So with that, we'll lead to our second poll question.
Excellent. That was a very good review on the making sure that we're doing a thorough assessment, because that's one of the most things that's most important with laser therapy, is to make sure that you have the proper assessment before you're going to move forward with it. So definitely very good to give us that reminder for those two. So our next poll question is, why are you interested in laser therapy? Are you here to grow your practice, help your patients, keep up with latest technology, to help maybe a personal health issue, or to better learn to sell this product? I just want to remind you, too, we've gotten quite a bit of good questions already early on, so make sure you go ahead. If you want to try to get your question in, go ahead and send it in early enough so we can make sure we can prioritize it for you. About 75% today, Dr. Page, are here to help their patients. I want to make sure that they're able to do this. So that's the first one, and then basically to help with personal health issues and also to continue to grow their practice.
Thanks, Doug. So with the understanding of a good assessment to help with a differential, to try and make sure that we are actually dealing with someone who has a cervicogenic headache, now we need to talk about the best way to treat that patient based on what we know in the literature. What I tend to do, as I mentioned before, with chronic musculoskeletal pain, we have a step-by-step approach to our assessment. We also have a standard approach to our treatment, and then we call it more of a layered approach, where we use multiple interventions that are synergistic within each other and kind of layer those interventions with each other as we go through the treatment progression. Again, we use a layered approach for chronic musculoskeletal pain, regardless if it's neck pain, back pain, knee pain. We try to integrate these three different things into our treatments, going from a prioritization, if you will, of what's most important to take care of first, and then how do we progress that patient back to normal activity. So the three things that we really try to layer with these patients are modalities, manual techniques, and therapeutic exercise. And again, what I'm going to do is talk to you about those interventions and the literature that supports it. And I will tell you that there's not a lot of literature on the specific treatment or outcomes of cervicogenic headaches. One of those reasons is most of the literature is based on the diagnostic side. What are some of the risk factors, presenting things? There's a lot more evidence in the literature regarding cervicogenic headache patients in regards to how we do a better job diagnosing them or figuring out the etiology. On the other hand, the treatment side doesn't have as many intervention studies. So that may be a factor of the lack of incidence that's out there. It's always hard to get large sample sizes when you're looking at interventions. But what I did do when I look at the literature is, since these patients tend to have the upper cross syndrome, which is also consistent with those who have chronic neck pain, whiplash-associated disorder, what we do is I looked at the relevant literature in terms of chronic neck pain as well and kind of apply it into cervicogenic headaches as the best evidence that we have available. So we'll start with our modalities. Modalities, manual therapy, and exercise together provide that faster and longer lasting benefit in patients who have neck pain. So this study kind of validated our approach of a layered approach integrating these types of interventions. In terms of the specific modalities with cervicogenic headaches, the two modalities that are mentioned most are the TENS and the cryotherapy. TENS treatments obviously do very well, cryotherapy as well, but they usually have to be combined with other treatments. So again, within themselves, they're not as effective as when we layer them with other interventions. The other intervention that has some evidence in literature, again, particularly for chronic neck pain, not so much for cervicogenic headache, is low-level laser therapy. Now, we use laser therapy for a lot of indications based on what we know from the biology of laser therapy. We can get collagen formation, an increased healing rate, improvements in tensile strength, and obviously pain control. And when you look at the meta-analyses, the systematic reviews, the conclusion from several is that low-level laser therapy is effective for chronic neck pain patients. Some of the general indications that we use when using low-level laser include the temporary relief of minor muscle and joint pain, arthritis, muscle spasm, stiffness relief, helping the tissues to relax, and of course temporarily increasing that local blood circulation when we need to get a little bit of heat into that area. Now, when you look at laser therapy, it comes down to basically two key elements, and that's going to be wavelength and frequency. When you look at the light spectrum, you'll see that there is a wide spectrum of light from 460 to 960 to 1,000. And within that wide spectrum, there are two therapeutic windows. The lower therapeutic window, which is our visible red, and then the upper therapeutic window, which is our infrared. So we tend to use the wavelengths between about 600 to 900 in that range for our therapeutic effects. So if you look at this graph, this shows basically the depth of penetration of laser therapy is based on the wavelength. So as you see different wavelengths at the top of the screen, the 400 nanometers all the way to 10,000, you can then follow down the chart and find out how deep you're getting penetration. You'll see that anywhere in the 600 to 1,000, again, that therapeutic window is where we get the most depth of penetration. And that penetration also varies based on the level of the tissue that we're trying to reach. So again, we're staying within the 600 to 1,000 nanometer wavelengths. The next thing that we look at is the frequency. And when we talk about laser therapy, we define frequency, obviously, as the number of impulses per second. And by using a super pulsed frequency, we're able to get a very large burst of light in a very short duration. So when you have a shorter pulse width, you can have more power. And so super pulsed lasers that have these constant pulse trains can actually increase the mean output of power. So you're actually going to get that better therapeutic effect by doing short bursts with a higher frequency. Now, if we look at the different frequencies, just like we looked at the different wavelengths, there's basically two frequency areas or ranges that we talk most about. The 5 to 250 on the low end of the frequency spectrum is where we use what we use for repair, regeneration of tissue, influencing that immune response, and then producing the anti-inflammatory effects. So the lower frequencies are what we're going to do for the early on issues that we're going to have with trying to stimulate healing. The 1,000 to 3,000 hertz range is where we're going to start to see our pain reduction, decrease in swelling, edema, and reduce spasm. So we're going to be able to use different frequencies of the laser based on the therapeutic effect that we're trying to create. And again, we need to decide what exactly are we doing with the laser. Are we trying to decrease pain, or are we trying to promote healing? And if we try to answer those questions based on the different time periods in our rehabilitation, we'll be able to make a better clinical decision on which frequency to choose. The other variable is the depth of penetration of the frequencies. So a lower frequency is going to get a more absorption, a deeper penetration, versus a higher frequency in the 1,000 hertz range is much more superficial, if you will. As with any intervention such as laser, we want to make sure that we are informing everyone of the absolute contraindications. These are going to be things that we absolutely don't want to use a laser with, and that would be during pregnancy, anyone with carcinoma, body fever over 100.4 degrees Fahrenheit, or overactive hemorrhages. These are conditions where laser would be not used at all. Now, we do recommend that you avoid laser therapy over the thyroid, the eyes, the tattoos, or recent steroid injections. And so there are some relative contraindications, which means that you need to use your best judgment in deciding if that individual should receive treatment over these types of areas. But in general, we need to follow the absolute contraindications that there are an absolute no to laser therapy. So I'm a pretty simple researcher and clinician. I use the KISS principle, keep it simple, when we talk about how do we determine the best use of laser therapy for cervicogenic headaches. So this is the take-home slide, if you will, of how we can integrate it. Again, if you're using laser therapy, you need to have a reason why you're using it, what you're trying to accomplish, and then if you understand what you're trying to do within that treatment progression, then that'll tell you exactly what your parameters are going to be. So if we have muscle tightness, and remember, we do have more instances of a characteristic pattern of muscle tightness in our patients who have cervicogenic headache, which again follow Yanda's upper crust syndrome, particularly upper trap, levator, suboccipitals, pectorals. When those muscles are tight, or if we have trigger points, and we also identified some of the muscles that have specific trigger points, which tend to be the same muscles that are tight, we would choose that 1,000 hertz frequency for about 5 minutes with up to 3 times of a treatment in one sitting. We can also use laser acupuncture, which actually has been shown in the literature to be somewhat effective in working with these trigger points. Now at the other end, if you have pain, that deep facet pain, that person who has, remember that the cervicogenic headache affects the cervical facet, the upper cervical segments 1 through 3 usually, may also have some inflammation around those facets. We're going to use, again, a lower frequency. We want a deeper penetration. We want to influence that inflammation, and we can use 2-minute treatments at 250 hertz. Now we also get the question, well, if we're doing a layered approach and we're doing multiple modalities, how do we integrate it with how do we integrate laser with other types of modalities? The general consensus is we want to apply that low-level laser therapy before we do any heat or mobilization. And we also want to apply it after we ice the tissues. So that's kind of the rule of thumb of determining within a treatment session, use laser before we do heat or mobs or manipulation, and then use it after ice. So we've talked about modalities, and now we want to talk a little bit about the actual manual techniques that we can use as part of that layered approach in cervicogenic headache, or again, chronic neck pain patients for that matter. We'll talk a little bit about joint mobilization, manipulation, post-isometric relaxation, spray and stretch, instrument-assisted soft tissue mobilization, you may know as Graston or A-stem, and the kinesiological taping as well. So what does the literature tell us about cervicogenic headaches and cervical manipulation mobilization? Well, you would not be surprised to know that actually it's very effective. Patients who have cervicogenic headaches, this is going to be one of the most important treatments. It's going to be that upper cervical joint manipulation or mobilization, because as we talked about, it's a dysfunction of the first 3 cervical vertebrae, which again we theorize create that convergence into that trigeminal cervical nuclei which is what's causing, we think, that headache pain. So if we can fix the source of the pain, the cause of the pain, which is actually those upper cervical segments, they tend to do better. But again, I always remind, no matter what, always do that VBA test before you do any type of mobilization or manipulation. The next manual technique that I recommend is spray and stretch. And again, this is because we do have those characteristic trigger points and muscle tightness patterns that we see with Yonder's upper cross syndrome in these patients. Spray and stretch has been around for a long time, was popularized by Dr. Janet Travell and used for trigger points. And she has some very excellent textbooks, which I recommend any chiropractor, PT, anybody should have that works with chronic musculoskeletal pain should have those two books on their shelves. Spray and stretch was out for a little while. It was off the shelves, but it's come back. I'm very happy to see it on the shelves again, and I highly recommend using it because what it does is it provides this very fine stream spray of a vapocoolant, which we can spray along the muscles, which has been used effectively to treat the myofascial pain and trigger points. Again, not just in cervicogenic headaches, but in other types of chronic musculoskeletal pain as well. The next manual modality that we use is instrument-assisted soft tissue mobilization. This is basically based on the left side of your screen, you'll see that's called a gua sha tool. Gua sha literally means to scrape from the Chinese medicine. Many, many years ago, they would use bone, horn, stones, different things to just scrape the skin to create this therapeutic effect. And then several years ago, these instruments were developed, which are still used to, again, scrape and create a great reaction of the collagen underneath the skin where we have this instrument-assisted soft tissue mobilization. So the soft tissue mobilization you obviously can do with your hands, but what happens is it tends to wear your hands out, and you don't, I find personally, that I don't get a good feel as well as I do when I'm using these stainless steel instruments. These instruments are from the Graston technique. There's also instruments from A-stem. There's also many other types of instruments. I personally recommend the Graston instruments because they do provide really good feel in my hands and some good feedback as you're trying to mobilize that soft tissue, which again, you're going to see a lot of those issues in patients who have this chronic cervicogenic headache or neck pain. And finally, we recommend the kinesiological taping. This has, again, become very popular in the past few years. There's not a lot of research that supports its use, obviously, in cervicogenic headache, but we do have a lot of anecdotal evidence, and probably the literature is about half and half, I'd say, about showing positive effects of kinesiological taping. Basically, this type of tape is a flexible tape which stretches over 100% of its original length. We apply it directly to the skin, and what I kind of call it is more of a proprioceptive taping. It kind of integrates with the sensory system, and so you're using the receptors in the skin to help send proprioceptive information through that system, that afferent system, to give feedback, and also to just in general, depending on what we're trying to accomplish with that tape, we can stretch it more, we can stretch it less, we can do all kinds of different things to get the effect that we're looking for. What's great with these types of tapes is that they tend to be latex-free, water-resistant, and breathable. In general, we can use this type of tape for 3 types of applications: microcirculatory, meaning that we can affect the circulation just under the skin. In theory, we can create more fluid movement underneath the skin, lymphatic flow. We can also provide neurosensory input, which is what I described by placing the tape right over the skin and creating that sense of something on the skin, stimulating touch receptors. And then we can also use this tape for structural intervention, meaning if we need to actually change the position of something in terms of supporting the shoulder or the knee or something to that fact. So with that, we'll take a little break and go to poll question number 3.
Excellent. Thank you very much, Dr. Page. Which multi-radiance medical product would you like to get a little bit more information on? The MR4 laser therapy system, our laser stem emitter, one of the sports packages, the in-clinic and in-field devices, any of our portable devices, or our cosmetic and or veterinary devices? Dr. Page, we got a lot of really good questions, especially during the technique portion when you're going through those things. So we have a lot of really good questions. Here's your chance. This will be our last break before we go into our Q&A session. So I just want to remind you, if you do have a question that you want to make sure that Dr. Page has a chance to answer, go ahead, send it in right now. I'm prioritizing all the questions for him right now. So you got a few more minutes where you can throw in a few more questions. So with that, I'd like to we'll look at our thing. Quite a bit of people are still interested in our MR4 laser therapy, and definitely into laser stem, portable, and even the cosmetic. So definitely a lot of interest in all the devices that we have. So with that, I'm going to let it get back to Dr. Page so we can finish out the last section.
All right, Doug, so we're finishing up with, we've talked about modalities, the manual interventions, and let's wrap it up with exercise again. Therapeutic exercise, to me, is probably the most important factor in any chronic musculoskeletal condition. We can reduce the symptoms and improve healing with our modalities. We can improve the biomechanics of the joint and reduce pain and improve movement with the manual techniques. But the exercises are what's actually going to heal the patient and restore the normal muscle balance. So let's take a look at what the literature tells us about, again, exercise with cervicogenic headache. Unfortunately, as I mentioned before, not a lot of exercise intervention studies on cervicogenic headache patients in general. So what I did was try to apply what does the literature tell us about patients who have chronic neck pain. My favorite exercise for any neck patient is Brugger's exercise, named after Dr. Alois Brugger, who was a Swiss neurologist who was very influential in terms of muscle imbalances and restoring those imbalances for normal function. What this study actually looked at was MVA patients with whiplash who did this simple thera-band exercise, which is a combination of different movements, and you can see this exercise at thera-bandacademy.com. What they found was within the first week no significant difference in a group that performed the exercise versus those who were in a soft collar, but it took at least 6 weeks for them to get better, and that makes sense. I mean, that's the normal neuromuscular adaptations that we see with resistance training. So that doesn't surprise us at all to know that this exercise was effective. The next exercise that's in the literature is the craniocervical flexion progression. Again, this is the same thing we used with the test of the pressure, using the pressure biofeedback as described by the Australians, Dr. Gwendolyn Joe. We actually have the patients lying supine, placing the device underneath the neck as we did in the test, inflating it to, again, 20 to 30 millimeters of mercury in these 2 millimeter increments. Or you can use a simple towel roll. You won't get the visual biofeedback, but it may be an effective way to tell the patient exactly what they're trying to do. And we progress the patient from a supine position. We do supine with shoulder abduction, sitting against the wall, or sitting against the wall and then performing abduction while they maintain this chin tuck and have the patients hold 10 seconds, 10 repetitions. Another study that looked at the use of thera-band in chronic neck pain was done by Van Edikoven, and what they did was looked at maintaining the cervical spine position while we put the thera-band around the head and perform different isometric contractions. The patient holds their head steady and then pushes the band out against the head. So it creates this dynamic vector of resistance where the patient actually maintains a neutral cervical spine and has to isometrically resist the force that's produced by the bands. Another key intervention in terms of therapeutic exercise is sensory motor training. Dr. Yanda noticed that this was an important intervention, and he kind of created this back in the 70s for patients who had chronic back pain, because what Dr. Yanda noted was these chronic musculoskeletal problems tend to be a central nervous system disorder, and the best way to treat the central nervous system from a functional approach is to do a very progressive, specific and progressive balance training progression. because he noted that the unconscious reaction, not the strength of a muscle, but its ability to turn on or off, is the most important thing that we need to train. And traditional strength training just doesn't address that issue of unconscious reaction or the ability to turn that muscle on. As Dr. Yonda would say, you can have a muscle that's as strong as any muscle in the world, but if you can't fire it at the right time, it's pretty much useless and will lead to more problems. So he developed the sensory motor training, and basically what we do with sensory motor as a progression is we progressively increase that proprioceptive input into the central nervous system using progressive unstable surfaces and a variety of different postures. Now we take sensory motor training, we break it down into three basic phases: a static phase, a dynamic phase, and a functional phase. So in our static phase, we're going to use unstable surfaces. We use foam stability trainers. We use rocker and wobble boards. We'll use stability discs. We progressively increase that level of instability. Then once we feel they're confident and comfortable doing that on a static level, we'll add dynamic movements such as arm and leg movements on top of unstable surfaces. And then we'll progress the patient to perform more functional movements on these same unstable surfaces. So these are some examples of what Dr. Yonda talked about in his sensory motor training. You'll see on the left of your screen, that's Dr. Bullock-Saxton performing sensory motor training with a patient in what Yonda called the half-step position on some thera-band stability trainers. And what we're doing in this situation is you can see that this is a great position to reactively facilitate muscles from the foot to the neck, because you have to maintain this position against gravity on an unstable surface. It's obviously not something we'd start off with, but it's one of our progressive exercises. On the upper right is an example of Yonda's short foot, where we actually teach the patient how to make their foot short, which Yonda talked about contracting the intrinsic muscles of the foot and making sure that we're getting good proprioceptive input. In the bottom right are Yonda's balance sandals, which he advocated to facilitate contraction of the hip muscles, particularly in patients, ankle patients. Now, some may be saying, well, why am I worrying about the foot when I'm talking about cervicogenic headaches? Well, that was one of Yonda's big points, was that the foot is an important proprioceptor. Based on the research that we know that the foot can control posture, can control gait, just those proprioceptors, those sensory receptors from the foot. So the foot's a very integral part of everything from literally toe to head. And so we find that using sensory motor training does do a good job in treating cervicogenic headache patients because it addresses the functional component of chronic musculoskeletal pain. Again, if we have someone who has a cervical upper cross syndrome or lower cross syndrome, doesn't matter, sensory motor training is indicated in a condition where we have that chronic pain mediated by the central nervous system. And we can progress our cervical patients even further with sensory motor training by using unstable surfaces, not just at the foot, but also at the cervical spine. So in this exercise, the patient has to maintain a neutral cervical spine, and then we can make it even more difficult, for example, performing the Brugger's external rotation exercise with thera-band. So in summary, we want to just classify cervicogenic headaches as patients caused by a neck dysfunction, particularly that upper cervical segments 1 through 3. We know that cervicogenic headaches are associated with that musculoskeletal dysfunction and characteristically Yonda's upper cross syndrome muscle imbalance. In order to properly address it, we recommend that 3-step approach, which is based on the best evidence that we have available to integrate modalities, manual therapies, and a functional exercise progression. So with that, I want to just recommend some of the textbooks that I found very effective in researching this and determining some more information. We have Yonda's Cross Syndromes website. We also have his textbook that we recently completed. The red books are Travell's Trigger Point books that I mentioned. There's also the book from on the very right by Gwendolyn Jull that talks about a lot of whiplash, headache, and neck pain and all the research that they've done on chronic neck pain. So with that, I want to thank everyone for listening, for Doug, for Multi-Radiance Medical, for hosting me, and I hope that this information is very helpful to you and your patients. And with that, I'll turn it over to Doug.
Excellent. Thank you, Dr. Page. We're going to go through, and we got quite a few questions. So we'll go ahead, and I think we should start a few with those. We got probably about 5 minutes left, so I think we can hit a few of these. someone was asking, do you have a reference for the Baduk article
Yes, I
that you were
do.
mentioning?
Yes, I do. Definitely can email that. If they email you at the, I guess, the webinar and you want to forward it to me, I'll be glad to provide that reference.
Excellent. Good deal. And there was a few questions. We'll go through the laser ones first, and we'll go through some of the other ones, too. Some of them were asking about, would you be doing any type of laser treatments over the cranium or directly over the spinal cord? Are those any locations that you might, as opposed to just talking about just the upper cervical, do you use any other points as well?
No, I personally would not do that. I think that that's not something that I'd feel comfortable doing personally. You may have some other ideas, Doug, based on your experience with lasers, and I'd look to you to answer that as well.
We don't generally do too much over the cranium in and of itself, other than, we might do something more toward lower, mandible, but we don't generally do to the cranium itself, other than maybe some of these laser hair regrowth things that I think you keep seeing on TV. But for the most part, over the spinal cord we do at some point. But for the most part, a cervicogenic headache doesn't seem to be a spinal cord situation.
Yeah,
so.
that was actually my point I was going to get to was I have no reason in patients who have cervicogenic headaches to be on the spinal cord. If anything, I'm going to be to the right or left of it, angled in, so I can get a good biological response from specifically that facet joint is what I'm interested in.
Does the method change any when you're working with children, and is there an age of which you might adjust the program?
I don't know that there's an age, specific age limit. I see young athletes. I see, older athletes. What I do is I look at what exactly that person's physical capabilities are, what their motor programs are like. Everyone's a little bit different, so I would definitely tweak the program based on the individual, but I wouldn't say that there's a specific age more than there's more of a specific motor ability that I look for.
Okay. When you're going to do any type of soft tissue mobilization, how deep do you generally get with that? How aggressive are you with your soft tissue mob?
People used to think that you had to go deep and create this huge painful reaction. What we're finding is that's not really necessary to go that deep. Now, what the literature does show us is that the more pressure that you apply, the more fibroblasts are activated. That's been shown in a study using the Graston instruments. But what you want to do is to basically, these again are more superficial muscles. I really don't see a need to go deep in these patients, and generally they're going to be in a lot of pain. And again, instrument-assisted soft tissue mobilization is going to be an adjunct. It's going to basically treat one of those symptoms of the muscle tightness, but in reality, the biggest thing that we need to focus on is that addressing the upper cervical segments with mobilization or manipulation.
Okay, excellent. One thing, someone just asked if you could click to the previous slide, just so that they could get the reference. There you go. Just so that they could catch those reference manuals off there right quick. So I just wanted to ask for that one real quick. Dr. Page, when you were deciding which techniques and which modalities that you were going to include in here, why did you choose the multi-radiance over something other like another brand of laser? What was it about that particular one that allowed you to fit it into your layered approach?
What I love about the multi-radiance is obviously its portability. Whether I'm going to the training room or if I'm in another clinic, I've got that unit that I can readily use and know, and I trust that it's giving me the wavelengths and the frequencies that I want. And then we also have the unit that can combine with electrical stimulation, kind of get 2-for-1 treatments, if you will. So I really like the fact that I can trust that this is what the frequencies and wavelengths I'm looking for with the standard protocols, all of the education that backs it up. Those are the things that make me want to use the multi-radiance laser.
Excellent. There's a question talking about the layered approach, and they had actually asked, I'm looking on here for it right now because I see, when you're doing trigger point work, do you just use a laser probe to deactivate it, or do you like to combine that with like some ischemic compression with the laser, or do you like that also with the cold? Do you kind of do them as like a combo, or do you do them
You know, I used to try to isolate the treatment effects and say, well, I'm going to see, I'll do a laser now by itself and see if it helps, or I'm just going to do spray and stretch and see if it helps. What I'm starting to see or feel personally is that let's go ahead and try multiple things all together at the same time, because there may be that synergistic effect. Instead of trying to isolate effect, I tend to try and integrate and use multiple things within obviously the treatment time and the indications that I have. So yes, I do try different techniques, and I always will evaluate the response and try something different if it's not working.
Excellent. And now, kind of one last on the technique question. Someone was asking, do you have like a specific K-tape pattern for the cervical correction for the imbalance? Is there a pattern that you like in particular?
Well, you just typically would follow the standard single muscle facilitation or inhibition if you follow the kinesiotaping method. But if you also follow things like Spider Tech, they do have the pre-cuts, which have this kind of built-in type of system based on the way that the kinesiotape is laid out in the Spider Tech. You can use that as well. I don't really have a standard application. I do it on a case-by-case basis.
Okay, so a little bit of an evaluative technique is going to be needed for that particular approach. We're just pretty much about done, but I would be totally amiss for not asking you this. Many people like the webinar quite a bit, and they'd love to be able to see if they're going to be able to get to see this somewhere. They might be able to learn or get some handouts or sort of thing. Where are you going to be teaching in the next couple of months? You know, like any of your schedules or anything like that to help them if they'd like to come learn this approach from you.
Actually, I'm going to be teaching Yanda approach in Korea and in China if anyone wants to make the trip in a few weeks. But actually, we're going to start our spring seminar series with Yanda approach. We also have a couple of other instructors who are teaching the approach. If you go to yandaapproach.com, you can also link to it from the Yanda Cross Syndrome's website to see our list of Yanda seminars.
Okay, excellent. A couple people want some bibliographies too. We can definitely do that. One thing, I know Dr. Page, we had talked about potentially archiving this at some point. So once Dr. Page makes a determination if he wants to do that, we'll let you know if we're going to archive the webinar for participants to be able to kind of get to review it again.
And I will also say that I just published a review paper on it in the International Journal of Sports Physical Therapy in the September edition. You can get that through my blog at hygienicblog.com. It's also available to download there under the article on cervicogenic headache patients.
Excellent. Excellent. Okay, well, with that, I think we're going to wrap it up for the afternoon. Anybody who we didn't get to your questions or anything, we will send them on to Dr. Page just so that he can go ahead and he can answer those back to you. And we will let you know once we decide if this is actually going to go up onto an archive spot, if it's going to be through Dr. Page or if it's something that we'll be able to do. And then we'll also include a listing of where Dr. Page will be presenting at in the next few months too. So if you want to go ahead and click us to the next. Just to let you know, our webinar for next month is actually going to be Effective Laser Therapy Protocols for the Knee. This is going to be presented by Dr. Chris Caraway. And we're going to be doing this on, I don't see the date on here for this. I believe it's somewhere.
It's November 10th.
November 10th is our next one. So we're actually going to do some treatments for bursitis, arthritis, post-surgical conditions, sprains and strains. We're going to really focus in on the knee. We're going to do a little bit of knee, foot, ankle as well, but most the focus of this is primarily going to be on the knee. If you want to go ahead and register, you can either go to our GoToMeeting website for that, or you can get a direct link from the Multi-Radiance Medical website. I want to thank Dr. Phil Page for presenting this for us today. I appreciate it very much. I know how busy you are with the teaching and the lecturing and everything, and to be able to get you on here today was a treat for all of us. So I really do appreciate that. If you do have any questions or anything, please go ahead. Feel free to give us a call at our 1-800 number. It's 1-800-373-0955, or you can email us questions at webinar@multiradiance.com. We look forward to seeing you in November. And as always, if you need anything, just give us a call.